Up next, I'd like to call up Dr. Natachai Srisawat. She's going to speak on target blood pressure to prevent AKI, higher or normotension.
Thank you, Professor Sorino. So this is the outline of my presentations, starting from physiology of renal micro and macro circulations. As we all know that the renal blood flow is occupied up to 25% of the cardiac output, while the kidney weight is only less than 0.5 of our body weight, which means this is a very high organ that need a high blood flow. And when we look into the complexity of the renal microcirculation, this let me think about also the complexity of the lane trees. And this kind of the complexity lead to the heterogeneity of renal tissue oxygenation on the various part of our kidney. And this also bring into the susceptible of the ischemic hypoxemic injury for the kidney. For the paradigm of renal microcirculatory dysfunction in sepsis, there are two main factors that normally we account on, including the low mean arterial pressure and also low renal blood flows. This is the summary table on the issue of the MAP, mean arterial pressure, on our renal function in sepsis. As you can see from this summary table, study in this field has been conducted for more than 30 years. And you can see that the MAP has been, most of the studies show the same trend, that the low MAP has associated with low renal, related to the renal dysfunction and low urine output. But we should not only focus on only the mean arterial pressure. To improve the renal pressure, the other thing that we may need to account on is renal venous pressure. We also need to optimize the renal venous pressure by controlling an optimal central venous pressure and also controlling some local factor, including the intra-abdominal pressures. In terms of the renal blood flow, as you can see that this is not quite a homogeneous study like in the MAP study. For the renal blood flow, the study in the large and the small animal study, more than 150 studies, show kind of the conflicting result. Some of studies show the increase of the renal blood flow, but some studies also show decrease of the renal blood flow. For the human study, we have 4 major studies that try to look for the renal blood flow and show the same thing of the conflicting results. 2 of the studies show decrease, 2 of the studies show the increase of the renal blood flow. One of the main explanation may be because of in the distributive shock or vasodilatory shock. At the early stage, there is an increase of the cardiac output and maybe increase of the renal blood flow. But if we study a little bit late, maybe we are confronted with the stage of low cardiac output and low renal blood flows. So to keep higher blood pressure target, there is like a double-edged sword. There is pro and con. In terms of the pro side, increase the MAP may improve our organ perfusion, micro and macro circulatory circulation, improve oxygen delivery, and reduce hypoxemic injury. On the con side, to improve the blood pressure target may need to increase the vasopressor, and that comes with the increase of some complications, including tachyarrhythmia, MI, digital ischemia, and valve ischemia. This is currently we have like 5 major RCT that try to explore the role of the higher MAP and improvement of the outcome. Most of these studies show using the primary outcome as the mortality rate. As you can see from this summary table from 5 major studies, starting from more than 20 years ago. One of the landmark study is sepsis PAM study, which is a randomized study, and you may all know this study quite well, that no any difference in terms of mortality between the high MAP group up to 85 to 90 compared to 7 to 75 MAP. However, in the subgroup of chronic hypertension, it seems that there are improvement and significantly lower rate of doubling serum creatinine and the RRT rate in this group. Follow with the study of the Ovation trial, which try to explore the same thing in the vasodilatory shock. But they found no any difference in terms of mortality, but there is significantly higher mortality in the elderly patients. This brings into the subsequent pool meta-analysis that also show that in the group of higher MAP, there might be increase of the mortality, especially if we studying the target or the vasopressor rate more than 6 hours. And also that's been into the most recent study, the 65 trial from the UK groups that study population in the elderly group more than 65 in the 65 ICU in the UK. What we found is again no any significantly different of mortality, but they found significant trend of increased mortality in the group that age more than 75. So current practice guideline by the Survival Sepsis Campaign guideline recommend based on the current evidence that we recommend to target the MAP at 65, not try to keep over MAP targets. But still, we still lack of much of the data from the primary outcomes such as acute kidney injury that lead into our recent meta-analysis that done by our fellows, Dr. Pu Thong Tan, that our fellows do the meta-analysis comparing the high blood pressure versus normotension target. And right now we specific and focus in the prevention of the acute kidney injury. In this study, we have recruit and enroll screening more than 8,000 publications, and we come up with the final study, 12 study in our final analysis. As you can see that we divide the study group into 3 major groups, the shock stage, non-cardiac surgery, and cardiac surgery. Most of the patient population is in the vasodilatory shock state, comprise more than 3,000 cases. And this is the lower target pressure and higher target pressure. What we found from the result is in the shock state, there is no any significant difference between the high MAP group comparing to the normotensive group in terms of the prevent AKI or reducing RRC recipient rate. But in the subgroup analysis of the patient, in this group for the shock patient, in the subgroup of chronic hypertension, we found a significantly lower risk of RRC recipient received in the higher MAP groups. So this might be explained by the shift of the renal autoregulation to the right side of the chronic hypertension. That by the increase the MAP may improve the renal blood flow and improve renal outcomes. So what we should do next based on the evidence that we have? Should we keep the high MAP or low MAP or just optimal MAP? From my point of view, I think we still may use the strategy that we call personalized blood pressure target. But how we can know that which the patient that will benefit from the higher MAP target? So right now, with the current technology, we have many ways that we can assess the renal macrocirculation. From this table list, you can see that we have device that mostly is non-invasive technique, such as renal Doppler ultrasounds combined with the contrast enhanced. We also have the way that we can also measure the renal macrocirculation, such as, again, the contrast ultrasound may be also another chance of us to assess our renal micro and macro circulations. Contrast enhanced renal ultrasound is a way that we use the contrast agent that containing the microbubble that behave the same thing as a red blood cell. So this is a way that we can assess our the renal microcirculation and macrocirculations. And this picture show that if the bubble can migrate throughout all the kidney cortex and medulla, may reflect that this patient has enough renal blood flow and may not require the high MAP targets. Another one that we may need to access for our in our case is renal hypoxia. Again, we have many ways also the chance to assess this one, including the new technology such as bladder urinary oxygen tension, the PuO2 that allow us to measure the medullary hypoxemia, which is the part of the kidney that is susceptible to hypoxia. We also have the urine biomarker that also may reflect any stress in the kidney, such as nephrocheck or NGAL that reflect the kidney damage in the kidney. So this is kind of the device that we may allow us to assess in the near future for local tissue hypoxemia, including our renal hypoxia. The bladder urinary oxygen tension, with this device, we can continuously monitoring the oxygen tension in the medulla, and might be another surrogate marker for our optimal target, the MAP. And also the current urine biomarker that quite widely used in the clinical setting, such as the NGAL or nephrocheck, also may be another marker to improve the patient selection. So my point of view, assessment of renal microcirculation and microcirculation, we may think about to use the device such as contrast-enhanced ultrasound or the medullary urinary oxygen tension. We may assess the renal hypoxia by any AKI biomarkers. And combining these two, we may conduct the future trials such as divide the study into two phases. The first one may be the discovery phase to assess the potential marker that can help us to triage the patient. To the patient will be most get the benefit from the high MAP. And after that, after we get the best marker, we may randomize them into the positive one to higher or standard MAP target. And this might be the way to allow us to find the right answer for the good candidate for the MAP target patients. So in my conclusion, the target higher MAP in shock and perioperative patient may not superior to normotensive in terms of reducing renal incident and renal progression. But the higher MAP over 70 might, in the shock patient who have a premorbid hypertension, may reduce the RRT administration and suggesting a renal protective effect. And currently, we still lack of the good randomized study. We still need more additional study to assess the benefit of the high MAP target for preventing AKI by using the renal non-invasive technique device that I just mentioned. Thank you very much.